I would like to update you a little bit on this head-to-head trial of a low-dose paclitaxel-coated device, namely the Ranger, which is, as you know, the product which is produced by Boston Scientific. It uses paclitaxel in a dose density of 2 microns per square millimeters, and it was compared head-to-head in a randomized fashion to a market-leading device like the IN.PACT Admiral device, which, as you know, uses a higher paclitaxel dose of about 3.5 micrograms per square millimeter. It was actually an investigator-initiated trial, which we were running out of our university in Leipzig, funded through a research grant of Boston Scientific, but the study was done with a lot of scientific rigor, independently monitored, with the Independent Clinical Events Committee, core labs for angiography and duplexes. We actually were running the study in 2 phases. The first phase was a pilot study of 150 patients, randomized 1-to-1. And we were just looking a little bit on the enrollment speed and so on. And then based on the initial data, there was an extension study fully powered to show to test a formal non-inferiority hypothesis. The total patient number is 414 patients. Both parts of the study have finished enrollment, and currently I'm able to show you the 1- and 2-year data of the first 150 patients from the pilot study. These were the clinical sites, 15 clinical sites in Germany participating in the study. We were looking at patients with Rutherford 2 to 4. Lesion length was allowed up to 30 centimeters, so a fairly, I would say, real-world cohort which could be treated. No severe calcification, and we were treating de novo and restenotic lesions, but no in-stent restenosis. Here you can see the patient flow chart and of the 150 patients, and retention at 12 and 24 months was actually quite reasonable. Here are the baseline and demographics, clinical demographics. You can see diabetes mellitus, about 35% of patients in both groups. In terms of lesion characteristics, in the pilot study, we had about 12 centimeter mean lesion lengths, about 40% total occlusions, and about half of the patients had moderately or severe calcification according to the core lab assessment. You can see here the procedural outcomes. Bailout stent placement was necessary in around 25% of the patients. And otherwise, the procedure was carried out with good initial clinical success. In terms of mortality, we can say that there was a balance of the death observed so far. In the pilot study, 3 deaths at 2 years, 1 in IN.PACT, 2 in the Ranger arm, and for the full cohort so far, we have 7 deaths, 3 in IN.PACT and 4 in the Ranger arm. So no differences here between the groups. Probably in terms of efficacy comparison, the most important slide is this one, the primary patency rate at 1 and 2 years. And we can basically see that the low-dose paclitaxel balloon, the Ranger, did equally well with almost a little trend towards better results here at the 2-year time point compared to the IN.PACT balloon. So in summary, that's the first head-to-head randomized comparison of a low-dose DCB with a higher-dose DCB for femoral-popliteal interventions. We treated a complex real-world lesion subset with lesion length 12 centimeters and proportion of CTOs up to 40%. Actually, excellent efficacy at 2 years was recorded for both tested DCB. And similar primary patency rate was demonstrated so far for the low-dose Ranger compared to the IN.PACT DCB. And the full data set of the 440 patients will be available next year, January, at the LINC meeting. Thank you very much.
Thank you, Leo.